hello everyone. Welcome to this. This is the 9th session of our program that consisting of 13 webinars. So as said, again, welcome to this program that is named ERN-EuroBloodNet Topic on Focus for Willebrand Disease for Patients, Organization and Care Professional. And this program is a joint program, indeed, coordinated not just by the ERN-EuroBloodNet, but also by the umbrella patients organization, the European Haemophilia Consortium, that my colleague Daria will soon present, and that is represented by the EHC Willebrand Disease Committee and patient representative, among which Baiba Ziemele, who is the ePAG of the ERN-EuroBloodNet. This is the connection we have for this program that is also created in partnership with EURORDIS-Rare Diseases Europe and also supported by member of the scientific committee. So I would like to thank Professor Sophie Susen, Professor Jeroen Eikenboom, and Professor Flora Peyvandi. Daria, do you want to introduce the organization?
Of course. First of all, let me introduce myself. So my name is Daria Camilli. I'm Educational and Communication Manager at the European Haemophilia Consortium. And before I start introducing the EHC, I would like to thank the ERN for this program. And that's already the 9th time when I do it, because I always like to start with thanks, these webinars, because it is a unique project that we created together. It's a true collaboration between the ERN-EuroBloodNet and the European Haemophilia Consortium. So a few words about the EHC. EHC is an international non-profit organization representing 47 national patient organizations for people with rare bleeding disorders from 27 member states of the European Union and most members of the Council of Europe. We represent approximately 120,000 people diagnosed with a rare bleeding condition such as hemophilia, von Willebrand disease, and other extremely rare bleeding disorders across Europe. Among those, von Willebrand disease is the most common bleeding disorder, affecting up to 1% of the general population. However, it is still often neglected and overshadowed by hemophilia. So this program aims to distinguish von Willebrand disease from hemophilia and focuses on the particularities of this specific bleeding disorder. In the framework of this program, we discuss very topical issues related to von Willebrand disease among patients and healthcare professionals. And we aim at giving visibility to the challenges of those living with this condition, including quality of life, access to treatment and care, medical services available in Europe, diagnosis, treatment options, and the overall patient journey through life. And as Maria Angela already mentioned, today is our 9th webinar. And today we focus on a very, very important topic. We focus on maternity, is the second topic which we devote to women with von Willebrand disease specifically. And with this, I give the floor back to Maria Angela for some more information and housekeeping rules.
Thank you so much, Daria. So indeed, I start from the announcement, as you may know, that this program is accredited, because it's true that the main target is patients' organization, but we also aim to arrive to healthcare professionals like GPs, nurses, and so on. So the body of accreditation is the European Body of Accreditation in Hematology. So it provides continuing medical educational credit points. For receiving them, you need, well, to participate to this webinar, please check that your name and surname are properly written in the platform. And then at the end of the webinar, you will receive a short questionnaire, is a satisfactory one. And by answering, it will only take 1 minute. That will be just, the final part for receiving the credits. The instruction for receiving the credits, you will receive them at the end of the full program, knowing to how many sessions you participate. That will be the correspective credit you could take, like 3 webinar, 3 credits. So we will tell you that and give the instruction, no worries for that. Some home rule before starting. So as you can see, this session is recorded. If you don't feel comfortable, you can switch off your camera, change the name in the platform, or just like notify to me. And then your microphone will be muted along all the presentation. And at the end, there will be a Q&A. So that will be the occasion for unmuting yourself and take the floor if you prefer to express your comment or raise your question orally. Or if not, what we suggest is to write your question during the presentation in the chat, and we will take them at the end of the presentation. Usually this program consists of multiple speakers. So today, for this important topic of maternity, we'll have 4 speakers. So I'm glad to introduce Professor Karin van Galen from University Medical Center Utrecht in the Netherlands, and Professor Rezan Abdul-Kadir from University College London in UK.
And I have the pleasure to introduce to you Debra Pollard, who serves as the lead nurse specialist and advanced nurse practitioner at the Katharine Dormandy Haemophilia and Thrombosis Center in the UK. And she's a friend of the EHC, and she has been involved for years in support of the patient community. And also, I want to introduce to you Traunter, who serves as the trustee at the UK Haemophilia Society. And she's also co-chair of the EHC Willebrand Disease Committee. Jo, the floor is yours.
Okay, thank you very much. And good afternoon, everybody. And I'd like to echo what Daria has just said, and thank you so much for joining us today and listening to what we have to say. So my name's Jo, and I'm here to share my own personal journey about being a woman with von Willebrand disease and how that's shaped my experiences of pregnancy and childbirth. I had 3 children, and I'll kind of work my way through each of those 3 pregnancies. As everyone who is here knows, VWD is a bleeding disorder that affects blood clotting, and although it's relatively common, loads of us live undiagnosed for years. So I was 37 and on my 3rd baby before I actually got a diagnosis. So each of my pregnancies was unique, each challenging in its own ways, but all of them really was sort of underscored by my eventual diagnosis and then the support that I got once I did get that diagnosis and the impact that had certainly on my life and actually subsequently my children's lives as well. So the first pregnancy, so at the time that I had my first baby, I had no idea that I had VWD, but I did know that I had a tendency to bleed. And that was something that had been mentioned all the way through my life, and it was on my medical notes, etc. So from the beginning of the pregnancy, I suppose what really alerted to me that something was a bit different was that I experienced continuous bleeding. So it was quite a while before I actually even realized I was pregnant, because the bleeding carried on for about the first 4 months of pregnancy. Later on, I realized that much of this was possibly connected to implantation bleeding, and I have since spoken to other women who did have particular problems with implantation when they had VWD. So despite those challenges, the second half of the pregnancy was relatively okay. It was all good, and then I gave birth 9 months pregnant, everything textbook at this point in time, but I did suffer a postpartum hemorrhage. And I can remember the staff looking particularly confused as to where it was coming from and why it was happening. But eventually that was under control. and everything's fine. I went home, took my little baby home, who was absolutely fine. And then 6 weeks later, I had another hemorrhage and was rushed back into hospital. And I now know that my sort of post-pregnancy bleeding levels must have fallen to the point where it had prompted some more bleeding, and it had started again. So I finished up with another couple of days in hospital. But at this time, I had no answers. I had no clear explanation. I didn't have a diagnosis. And to be honest with you, I found it a little bit frightening at the time because I wasn't sure if this was normal. So then I got pregnant again 2.5 years later. And once again, my bleeding started, and that was right from the beginning. And it continued for the first 4 months, exactly the same as last time. And this time, the doctors identified when they were doing the scans, they said that there was a hematoma under the placenta, and that was where the bleeding was coming from. So basically, they could see it on the scan, but it just continued and continued. But again, at about 4 months, that seemed to calm down. And I thought, okay, I know what's happening now. I know that now everything's going to be okay. But then they said that my baby was in a transverse lie and that I had a placenta previa. So my placenta was lying over the cervix. So this was going to be a C-section. And I was okay with the idea of a C-section. And they gave me a date, and they decided that the baby should be born a month early. To make sure that I didn't go into any early labour. Now, they decided that I couldn't have an epidural because although I didn't have a diagnosis of VWD, I did have all over my notes that this lady, you know, has bled and has a history of bleeding. And actually, the last pregnancy, there was a couple of hemorrhages at the end. So they were cautious with me this time. And while baby was delivered perfectly safely a month early and she was perfectly healthy, they did, as you can imagine, doing a C-section on a lady with VWD when they don't know that that's what they've got, there was excessive bleeding, and they found it incredibly difficult to control. And I think that the medical team themselves were a little bit spooked by the bleeding afterwards. And at this point in time, they said, right, we definitely need to get you to a hematologist at this point. It's a bit disappointing that I actually managed to get to that second baby before they got to the point of saying, oh, maybe we didn't need a diagnosis. Now, I didn't become pregnant again for another 9 years. And this time I got pregnant with my third baby. I still didn't have a formal diagnosis because although I had, the doctors had said, we need to get to the bottom of why you bleed like you bleed, no referral was made. So I still didn't have a diagnosis, but luckily for me, the anaesthetist who delivered my second baby in the C-section, he saw my notes and he remembered my second pregnancy and my second delivery. And I think he decided that he wasn't going there again. So he gave me a ring and said, we're going to refer you to hematology because we need to find out what's happening here before you get to the point of delivery again. And it was through that referral that I learned that I had Willebrand disease. And that was very much kind of, it was a relief to have an explanation, but it was also a little bit of frustration that it had taken so long to get to this point. Now, this pregnancy, because I don't seem to do pregnancies easily or in an uncomplicated manner, I was diagnosed with something called placenta accretia, and that's nothing to do with Willebrand disease, but it is quite a serious condition where the placenta has grown too deeply into the uterus wall, and that increases the risk of severe bleeding. So I also had a placenta previa again, and so this was now classed as a very high risk pregnancy. So again, as I did with all my other pregnancies, I bled through the beginning of pregnancy for the first sort of 4 months. But then they kind of got to the point where they realized what was happening. They admitted me to hospital, and I spent the pregnancy in hospital where they felt more comfortable. They could keep their eye on me. At 32 weeks, the bleeding became really unheavy and they weren't able to control it. So they formed a C-section 2 months early, and my little boy was delivered. He was remarkably healthy. but they couldn't stop bleeding. And even though they now had a diagnosis of VWD that the haematologist had come to, and they'd been able to give me the proteins, etc., they still found that the situation was too complex, and they did an emergency hysterectomy. But even though that happened, I am thankful that I had that diagnosis, that I had the expertise in the room, I had the haematologists, I had the all of the experts there around me, and so I felt looked after at this point in time. So although it was complex, I felt relatively safe that they were looking after me. So reflecting on that journey then, I am really grateful for that anaesthetist who remembered me, and then that haemophilia team who sort of stepped in and really looked after me throughout that pregnancy, because I do think their expertise was life-saving. My diagnosis didn't just change my life, it changed my children's lives too. And after my third little boy was born, we discovered my eldest daughter and him himself had also inherited the condition. But having that diagnosis from the start has really made all the difference. And my daughter had a baby last year. She became pregnant, and the reassuring thing is she had the full support of her medical team, and she had treatment plans in place, her levels were monitored, her pregnancy was safe. And for me, knowing that, her journey was so much easier than mine, and that's brought me a lot of peace lately. So I suppose to end my story, this is very much about advocacy and resilience and the power of a diagnosis. And it's also a reminder of the importance of being heard. And, you know, that can potentially be life-saving. So thank you for letting me share my story. I hope it inspires you to have conversations or ask questions or take actions that can improve the lives of others with VWD and bleeding disorders. I'm going to hand you over now to Debra Pollard, and Debra is a haematology nurse, and she can tell you what happens from that sort of nurse practitioner perspective. And if anybody has any questions, then I'd be happy to hear from them when we open the floor to questions. Thank you.
Thank you so much, Jo, and thank you very much for inviting me to join you this evening. I was intrigued when I saw the title that I was going to be talking about family planning. I'm neither a family planning nurse or a midwife, but I hope that I'm able to talk you through some of the issues that I believe are important. Now, excuse me, it's a long time since I've done this. I can't find my advancing slide.
So Debra, if you click on your keyboard,
yes,
you know the button for going up and down.
It's working. It's okay. It's working.
Great. Thank you.
Clearly wasn't pressing hard enough. So I'm going to start, and I know that perhaps Rezan and Karin will also show you this slide, but I think it's so important that a lot of work went into developing the European Principles of Care for Women and Girls with Inherited Bleeding Disorders. And this was truly a collaborative effort between EHAD and EHC, so combining the views, the opinions and the experiences of clinicians and of patients and NMOs. So I think it's really important to remember that these are here. But what I was just going to focus on a little bit here is what's really appropriate about care, either before, during or immediately after pregnancy, and why that's important. So one of the principles is that we have comprehensive care of bleeding disorders, and that we include a family-centred approach to include the patient, the women and the girls with the bleeding disorders. And so at every step where I'm talking today, if I say woman, I mean woman and girl. If I say The woman, I mean the couple, because frankly, you don't get a pregnancy without two people. So I am not leaving out the men, although I think we're a bit man-light in the room today. We did talk about the provision of preconception counselling and access to prenatal diagnostics. And I'll touch a little bit on why I think that's important. And I'm sure that Rezan and Karin have opinions from the clinical perspective as well. And then an awareness of the additional challenges faced by women and girls with bleeding disorders throughout the lifespan. And of course, here I do mean the provision of patient-centred comprehensive management plan throughout pregnancy, but please, 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 it begins a long time before pregnancy. If we have a diagnosis, we should be talking to our adolescent group about what their options will be in the future. So I don't want to stick it there at just pregnant women. It's frozen again. That's not very helpful, is it? There we are. So when we think about family planning, what does this mean? And I think very much, I was reflecting while I was writing the slides, and I think very much about a young woman who at the time was only 12, 13 years of age. She'd just started high school. And she had a diagnosis of von Willebrand disease. She's from a known family with von Willebrand disease. She'd been cared for with us since she was born. So we had a good relationship with her. And this is why I go on to say, when does this conversation about family planning start? Because for her, at 12 years of age, it was her primary question: will I be able to have babies? I really want to be a mum, age 12. Interestingly, the day that she first raised it, it wasn't our priority because she'd just started her periods and we wanted to keep her as well as possible for as long as possible. And one of the teams said, we can have that conversation later. And unfortunately, as we later discovered, her interpretation of that was, I won't be able to have babies. So we have to be very, very careful with every conversation that we have, and we have to think about who should be involved in the conversation, because obviously as women and girls we turn to our mothers, aunts, grandmothers, all of whom may have had a bleeding disorder. We heard from Jo that sadly many women don't have a diagnosis early enough to go through this process, but I think I'm very much thinking here about people that do have a diagnosis. And so I believe really strongly that girls and young women need good education from their healthcare professionals, but also from their NMOs. They need precise knowledge of their von Willebrand disorder, because it's no use having the same conversation with a young lady who has moderate von Willebrand, moderate type 1, for example, with levels perhaps in the high teens or the 20s, factor 8 and von Willebrand factor levels in the 20s or even into the 30s. That conversation is going to be very, very different to the conversation that is needed for a woman or girl with a severe form of von Willebrand disease. So here I'm thinking type 3, but also severe type 1, severe type 2 genotypes. The conversation is also different around inheritance of the disorder, depending on the type of von Willebrand. And again, it's no use having the same conversation with a type 1 to a type 2M, for example, where we are talking about autosomal dominant or autosomal recessive disorders, mixing them up if we don't know which one we've got. So the young lady must know what type of von Willebrand she has, so that whoever she comes across can counsel her effectively and appropriately. Options for pregnancy and care can begin in adolescence, very gently, very slowly. We may also be talking about contraception we may be considering a contraceptive device or a contraceptive medicine as treatment for heavy menstrual bleeding, but also as prevention of pregnancy. The thing with that is that that stops the heavy menstrual bleeding, and there could be quite a lot of fear about stopping that treatment in order to become pregnant. Will the heavy menstrual bleeding come back? How will I manage that if I don't want to take a hormonal treatment? And of course, personal journeys like Joe's and family experiences can have a huge influence about planning future pregnancies. If there has been a terrible transition through the menarche, so when periods started, or if other female members of the family have had bad experiences in pregnancy and delivery, this can pass down in the family history and in what young women believe. So their personal knowledge of the disease is really important, their personal knowledge of how it is managed. And what we want to achieve is empowered women who can advocate for themselves in all healthcare situations. And the reason for that is because they're going to encounter many varied healthcare professionals, not all of whom will understand von Willebrand's disease, not all of whom will understand the specificity of von Willebrand's disease and pregnancy. So what are the questions that women might consider when planning a family? Well, of course, there's the, is it right time for me? Is it the right time for us? Who do I talk to? Do I talk to my family? Should I talk to my treatment centre? I would advocate that you should talk to both. Where do I go for information? And that very often starts within the family. It may start within the treatment centre if they regularly attend a treatment centre, but it also goes to Dr. Google. And unfortunately, I did avail myself of a Dr. Google search for looking at von Willebrand's and pregnancy, and you can see some very scary things about von Willebrand's and pregnancy if you just look on the internet. So we should consider guiding people very much towards treatment centres, national membership organisations. They will be worried, as I said, about stopping their current treatment. They will be concerned about how to conceive if they're bleeding all of the time. There's also some very general questions before pregnancy around, are there things I can do to keep healthy? Suggestions around folic acid supplementation, for example, perhaps eating a healthier diet, perhaps taking some supplementation, again, things that we would wish them to discuss with my clinical head on, and I know it will come up in the following talks. Have they had a recent check of their iron level? Are they taking iron supplementation? And I know that will come up later. And then, you know, babies come along sometimes when we didn't plan them. And so sometimes the conversation is, I'm already pregnant, but I didn't plan it. Help. And that's help from family, help from treatment centres, and possibly also help from NMOs. And I've put the picture of the man here because I said at the beginning, partners do have questions too. And so we're looking after two patients if we are clinicians or if we are people who give advice, because we're thinking about the mother and the baby, and we mustn't ignore the male partner's needs. Education programs for patients are really important, but so are education programs for healthcare staff. I've been a haemophilia bleeding disorders nurse for 34 years. I knew nothing about bleeding disorders when I worked in a surgical ward, when I did my midwifery placements, when I worked on a renal unit for 4 years. I'd never, ever heard of it. I'd heard of haemophilia. Do you know what? I didn't know anything about it, but I'd heard of it. So we can't expect all clinicians to have a knowledge of the bleeding disorder. I like to advocate for a single point of access within a treatment centre for women and their partners to be able to contact. It's a very confusing time. You're being looked after by the haematology service, you're being looked after by the obstetric or maternity service, you're meeting midwives, you're meeting obstetricians, you're meeting anaesthetists, and it's really nice if you can have one person that can tie everything together and be your first point of contact for, I've just had my scan, will somebody look at it? I've just had those blood tests you asked me to get, can somebody tell me if they're okay? So I'd like people to think about if it's possible to have a healthcare navigator for pregnant women who does arrange their scans for them, who does think about their first trimester and third trimester levels and getting them in a diary for them up front already at the beginning. And it's really important to have standard management care plans. And if we standardise things, they become familiar to others within the institution, particularly in healthcare. So when people see things again and again, they recognise them, they know who to call, they become more familiar with them and more confident in caring for people with von Willebrand's. And of course, I would say this, but wherever possible, we should consider a joint haematology obstetric clinic as a sort of one-stop shop for most of the needs. There will, however, be fear and anxiety. And I say that as a woman and as a mum, because all women have some fear and anxieties around pregnancy, labour and delivery. And all women have some fears around what will happen to their babies. Some women with von Willebrand's may have experienced significant issues during their adolescence, like awful heavy menstrual bleeding that may have taken quite a while to get on top of. They may have required a lot of intervention from healthcare professionals. And if they had one of those complex journeys that Jo described, their diagnosis may have come after quite a lot of healthcare interventions. And some women with von Willebrand's, I think I've already said, may have experience of other female family members who've had poor experiences. And so they're going to be very keen to avoid those bad experiences and very anxious about what might happen. In an ideal world, and we don't all live in an ideal world with good resources, but treatment centres should be able to have access to psychology and counselling, and it may actually be present within an obstetric service, even if it isn't present within a haematology service. And that should be accessed if anxiety becomes unmanageable and really starts to overtake what should be a really nice period in life. And we should consider not that there's any higher risk, but the postnatal depression risk should be considered if there are complications because of the von Willebrand's disease with the labour, delivery or postpartum period. And primary care or community physicians, whoever's going to be looking after this lady who's delivered, should be alerted to their discharge. So there are additional considerations for all couples affected by any of the bleeding disorders. I hope that I've shown a little bit, and that my colleagues will go on to show that with good preparation and planning, optimal management should be understood. The safety of the mother and of the child at all stages is paramount. And not every healthcare professional understands von Willebrand's disease. And if you're a woman or you are an NMO who talks to women, please remember that not all healthcare professionals understand von Willebrand's. So education, that's key to self-advocacy, and that promotes better outcomes for all, mothers, babies, families. I'm very keen that all women get to carry their management plans, so their treatment plan that should be drawn up with them, not without them, but their obstetric management plan, if they carry it in their hand and they are away from home when baby decides to come and they end up in a local hospital that wasn't expecting them, they've got the plan. The plan includes how to contact their haematologist, how to contact the people that normally look after them. So treatment centres and NMOs should empower women and their partners to actively participate in their care. And I just add on the end here, and it is one of our principles, that we need further multi-centre, multinational research into what women want I'd like to see that carried out to define future service developments. And with that, I'd like to hand over to Rezan.
Thank you very much, Debra. Can you see my slides?
Yes, thank you.
Yeah, thank you very much, Debra and Joe. Lovely presentations. So in this presentation with Dr. Van Galen, we aim to cover aspects of pregnancy care, actually, as Debra mentioned, which starts well before pregnancy, from preconceptional counseling throughout the pregnancy, delivery, and postnatal period. I think we have a presentation, and hopefully we have time for questions later on to discuss important area. But in this presentation, we focused on the important areas that was highlighted by the community in relation to maternity. So yeah, I have the same problem moving my slides. Okay, so one of the very common questions that asked by patients, other healthcare professionals, whether von Willebrand disease has any impact on fertility or early pregnancy implantation and development. Well, data in this area is really very limited, but we don't have any evidence to suggest that von Willebrand disease has any direct impact on women's ability to conceive or to have a normal early pregnancy development. Early pregnancy failures recurrently only reported in 2 factor deficiencies, and these are severe fibrinogen and factor 13 deficiencies, because as you can see here, these 2 factors act as a glue between the cytotrophoblastic cells, which is the outer cells of the gestational sac, and the residual cells, which is the lining of the in the uterus, the endometrium. However, maybe that von Willebrand disease has indirect impact on women's ability to conceive and keep a normal pregnancy development, because most of the women have heavy and prolonged period, and then really this impacts on their health and quality of life, their sexual marital relationship. We heard that from Debra. And also it may be that impacts on the quality of the endometrium, because it's shedding all the time, so it's not ready to receive the developing gametes. But we don't have data in that area, and more research is required. The second common question we get is that does von Willebrand disease increases risk of miscarriage? Well, let's see what is miscarriage. Well, miscarriage is a spontaneous loss of pregnancy before baby reaches viability, which still in the box defined as 24 weeks gestation, but we know now this has come down to 22, because after 22 babies are viable because of the good neonatal services. So the miscarriage itself is very common among the general population. About 15 to 20% of pregnancies miscarry before 13 weeks gestation, and that's first trimester miscarriage. Another 1 to 2% miscarry between 13 to 24 weeks gestation. And we have various types of miscarriage: incomplete, complete, inevitable, missed, but we don't have time to go through them. But we know that in the majority of cases, especially very early miscarriages, that the reason is chromosomal abnormalities, up to 60% in the first 10 weeks of gestation. Other causes are immunological, hematological, abnormalities of uterus, and so on. And we have another category called threatened miscarriage. Threatened miscarriage is a condition where vaginal bleeding happens, but the miscarriage is not yet confirmed or has not happened. And once we do a scan, if the fetal heart is positive, majority of these pregnancies continue, more than 80%, especially if the bleeding is not heavy. So what about the von Willebrand disease? Does it increase risk of miscarriage? Well, again, most of the studies we have are retrospective studies, and they show no difference in the pregnancy loss rate before 24 weeks gestation to in von Willebrand disease compared to the general population, and this including studies in women with severe type 3 von Willebrand disease. However, we in our center reported that women with Willebrand disease more likely to have a threatened miscarriage, which is a bleeding, but luckily does not lead to pregnancy loss, like the one Joe discussed, because they are more likely to bleed, but luckily does not lead to a pregnancy loss. And it is sometimes considered to be due to the fact that women with Willebrand disease, they know they are a bleeder and they may report any bleeding to the healthcare professionals, although Joe did not know she has von Willebrand disease, but her bleeding was considerable. So, but what we know for sure that women with Willebrand disease, if they miscarry or if they have a termination of pregnancy, they have a significant risk of bleeding. And studies show that 10% of them are readmitted again because of the bleeding after miscarriage, and 10% could require a blood transfusion. So now I hand over to Dr. Van Galen to discuss for us how we manage miscarriage and termination of pregnancy.
Yes, we have to work together. So it's very nice to have this presentation as a dual presentation, a double presentation. So when a woman arrives to our clinic with a miscarriage or a wish to terminate her pregnancy, there are one option in the miscarriage is that it comes spontaneously, but sometimes it's retained, and we need to do an operative termination of the pregnancy. And then that's with a mechanical or a medication procedure. And if that is about to happen, we start tranexamic acid to control the bleeding. If we know when the procedure is being performed, then we can start 4 hours before it. And if there's an miscarriage that will be started with medication, then we can start tranexamic acid at the same time. In mild von Willebrand disease types, we only will use desmopressin if excessive blood loss occurs, but it can be that the tranexamic acid is enough to prevent excessive bleeding. And in the more severe types, we will need to correct von Willebrand factor before the procedure or when the blood loss begins, depending on how the termination will go. And if it's a desmopressin, if the woman is known to respond to desmopressin, we can try that first. If it's not working enough, then we need to give her a factor concentrate, von Willebrand factor concentrate, and even maybe repeat it after 12 and or 24 hours if the bleeding continues to be severe or reoccurs. The tranexamic acid needs to be continued for until the blood loss becomes a lot less. Back to you, Rezan.
Okay, so what happens if bleeding occurs after 24-week gestation? Well, this is called antepartum bleeding or antepartum hemorrhage. Well, antepartum hemorrhage happens in about 3 to 4% of pregnancy in the general population, often associated with adverse outcomes such as preterm delivery, abruption of placenta, small babies. But the data in relation to von Willebrand disease is very conflicting. Some studies showed increased risk of bleeding, some not. This data is a really big data. It's a national data from United States, CDC data. They showed that antepartum bleeding, i.e. vaginal, patients admitted to the hospital with vaginal bleeding during pregnancy after 24 weeks happen 10 times more than women who do not have von Willebrand disease. But if we look at the data, again, it's reassuring that it was not associated with increased risk of adverse outcome. There were no increased abruption, there were no increased preterm delivery or intrauterine growth retardation or intrauterine death. So back to you, Karin, to tell us how to manage patient antenatally.
Yes. So of course, because before conception, you need to start your anticonceptives. You need to stop your anticonceptives, otherwise you won't get pregnant. And then the heavy menstrual bleeding can reoccur. As Debra also mentioned, this can have been a traumatic phase in women's life with von Willebrand disease. So that we have to pay attention to this and make a good plan. So the women who wants to conceive feels safe about stopping her oral anticonception. There is an increased risk for mucus bleeding during pregnancy. There's more blood into your gums, for example, and tranexamic acid is not allowed during pregnancy because we don't know if this is safe for the fetus. But however, it may be acceptable to administer tranexamic acid locally for minor gum, nose, or wound bleeding, or anal bleeding in case of hemorrhoids. The use of desmopressin during pregnancy, that has been discussed, whether this is safe or not. And there's been a recent systematic review from Rotterdam, and 7 studies were included who reported on the use of desmopressin during 73 pregnancies. And it was used for prenatal testing, for termination of pregnancy, or obstetrical interventions, or bleeds, but that was quite rare. And no adverse bleeding events occurred, so it seems to be effective for the hemostatic part. However, there were some rare adverse events, including a seizure because of low salt in the blood of the women. So there have to be some precautions when you use desmopressin in the pregnancy. Especially be careful with fluid restriction. There should be a mandatory fluid restriction after the use of desmopressin. For the neonates, when it was administered during the delivery, it appeared safe, but we have to be a bit cautious because a lot of outcome data were missing, so we don't know for sure. In all cases, it's safe to use clotting factor concentrate in the pregnancy. It does absolutely no harm for the fetus, and it's very effective to treat bleedings. And sometimes it's even needed to start prophylaxis during the pregnancy. For example, if repeated excessive nosebleeds occur, or there's insufficient local hemostasis in certain surgeries, or what else may be needed. And then the blood bleeding can be managed. But in any case, it should be tried to manage, of course, also nosebleeds and with local hemostasis if possible. And also when it's vaginal bleeding later in the pregnancy, clotting factor concentrate could be used. However, we will discuss with the gynecologist because, of course, it's more often a gynecological cause of the bleeding, such as a placenta that's lying in front of the cervix, as Joe told us about. So the essentials from this paper on the desmopressin use in the pregnancy is that it's still debated, but it seems to be effective and safe. However, be cautious about the low salt levels by using the fluid restriction, and DDFP exposure during pregnancy seems safe for the child, especially during the delivery.
Okay, so now we know that the antenatal risks that and bleeding, how to manage. Well, let's think about labor and delivery. There are several risks and concerns for women with Willebrand disease when it comes to labor and delivery. One important one is that the question whether they can have epidural block for analgesia or anesthesia. We know that epidural or spinal analgesia anesthesia had made such a big difference for women to have a positive and pain-free experience in labor and have a cesarean section without the risks of general anesthesia. But this has been really controversial in women with Willebrand disease. And this is a survey that conducted through International Society of Thrombosis and Hemostasis, looking at practices of healthcare professionals internationally in like more than 30 countries, and over 100 clinicians responded, and to see whether they consider that women with Willebrand disease suitable to have this option. And you can see even in those with a mild type 1 or even just low von Willebrand factors, a considerable number of clinicians thought this is not suitable for them. And then these women are denied this good option, and which affect them having a positive experience and also have risks of general anesthesia, for example. The other important risk that in relation to labor and delivery, of course, we know is the risk of postpartum hemorrhage. Well, we know women with a bleeding disorder, and specifically those with Willebrand disease, at risk of postpartum hemorrhage, which we refer to as PPH, and this could be primary in the first 24 hours or secondary up to 6 to 12 weeks or, after delivery. And there are several studies to show high rate of postpartum hemorrhage, but this is a systematic review that shows that primary hemorrhage could happen in 32 to 34% of these women. In the general population is 5 to 8%, and secondary hemorrhage in 13% compared to 2% in the normal population. So we have looked at the concerns and the risks. How can we mitigate these risks? How to optimize care of women in pregnancy and give them a positive experience and a safe delivery for them and their babies? As Debra and Karin mentioned, this care should really start well before pregnancy with the preconceptional counseling and planning the multidisciplinary intervention or management in collaboration with the patient, and close collaboration between the Hemophilia Treatment Center and maternity units. So the preconceptual care is very important because that gives us an opportunity to assess the woman's type, severity of von Willebrand disease, her bleeding risk, for example, through assessing her BAD score, bleeding assessment score, see what are her bleeding history in the past, assess her coagulation factor. Does she respond to DDAVP? If she has any bleeding, should we give her DDAVP? And also to think about, is genetic testing and genetic counseling appropriate, which is usually for type 2 and 3. It's also the opportunity to optimize the mother's health, because these women always have heavy bleeding. We need to treat heavy bleeding, correct their anemia, and then identify their other medical and obstetric risk factors, and then put together a plan where these women should have antenatal care, who should we look after them, and give them advice to contact the right professional as soon as they're planning pregnancy or become pregnant. So back to Karin to discuss about genetic counseling, please.
Yeah, so genetic counseling is one important part of the preconception phase, and it can be done by a geneticist, or it can be done by the gynecologist and hematologist together in a joint clinic. And we should not forget that it can also be the male patient with severe von Willebrand disease, and then it's also important that he has preconception counseling about having 50% chance of a child with severe von Willebrand disease in the autosomal dominant cases, and that's the most type 1 and type 2 cases von Willebrand disease. When there are a few very rare types of von Willebrand disease, such as type 3 and 2N, who generally inherit recessively, so both parents have to be a carrier of the disease but don't have the disease, and then the chance of having a child with von Willebrand disease in a very severe phenotype is 1 in 4. And this is not dependent on sex, such as in hemophilia. So it can be a boy or a girl who's affected. That's 50-50. Okay.
So again, one important aspect that really been overlooked when managing women with von Willebrand disease and need attention from the preconception time is the psychological impact. There is plenty of data and evidence to suggest that having a bleeding disorder such as von Willebrand disease have a psychological impact on women and may influence their decision making when it comes to planning pregnancy and having a baby. Because as mentioned before, these women often have heavy periods and they're on hormonal therapies which are helping them, but they have to stop this hormonal therapy. They have a recurrence of heavy bleeding, so they will be really worried. They may have guilt feeling that they are passing the condition to their offspring bleeding. They may have a bad experience from previous pregnancy because they may have a bad postpartum hemorrhage. And of course, they are very scared of the future. This survey I want to show you that was done through the European Haemophilia Consortium of more than 700 women with bleeding disorders from more than 30 European countries. And you can see in the graph that 1 in 4 women thought having a bleeding disorder has significant impact on their decision making to have a first child or to have more children. And that is why this aspect should be really considered when we counsel them. Especially psychological impact is really important and should be part of the continuous care that's provided for these women through the Haemophilia Treatment Center. When they are pregnant, a multidisciplinary management is important, and especially close collaboration between the obstetric midwifery team and the Haemophilia Treatment Center and other professionals such as anesthetists, pediatrics, when they will be looking after the baby. So Dr. Van Galen will talk to us about how do we manage pregnancy and what are changes in factor level. But what I want to emphasize here is the importance of having a birth plan. I consider formulating and discussing and making birth plan available one of the most important aspects of antenatal care. And this should be done really as soon as the pregnancy reaches the viability, because some women can go to preterm labor. And the plan should be really involving all clinicians that will be caring for these women, even those who are going to look after her in the community later on, and also in collaboration with the woman, because it's very important that we listen to the woman, what are her wishes, what are her expectations, what are her concerns, and this plan should really be available for her and every clinician that look after her. Back to you, Karin.
Yes, thank you. So what happens in pregnancy in all women is that the factor levels, this is factor 8, but it also is true for Willebrand factor, rises during pregnancy. And after pregnancy, it drops back to normal. But as you can see in these graphs, is that the general population rises much, much more than women with Willebrand disease. So there can be a rise depending on the Willebrand type. But it's not as big as in the general population, and the peak levels are lower. So this may be a reason why the bleeding occurs more often after delivery in women with Willebrand disease, and they are especially at risk for late postpartum bleeding. And Rezan will tell more about that too. And this is also a very important slide, because this is often undertreated. It's about the iron supplementation. Here in this graph, you can see that women also need more iron always because of her menstruation. However, when she gets pregnant, and especially the 2nd and 3rd trimester, there's a massive increase in the need for more iron to have a healthy baby. And it's also important for the mother for safe delivery, because if the hemoglobin levels are low in 3rd trimester, then the risk for postpartum hemorrhage increases. And it's so easy to treat and easy to diagnose that every hematologist and every gynecologist should be very aware and check levels and treat iron deficiency. Also for the neonates, because low iron can also cause some problems in the neonates, such as developmental problems or preterm delivery or cognitive developmental problems. So this is a really important thing that should not be forgotten. This is the same survey that Rezan showed earlier, and she was also a co-author of this paper, where 132 respondents from 39 countries said how they managed pregnancy and Willebrand disease, and there was quite some variation. So, for example, on antenatal monitoring of Willebrand and ferritin levels, there was a wide disparity. Also in how to optimally target your Willebrand levels in the delivery, and also how to monitor postpartum and even the definitions for postpartum hemorrhage differed, and suitability for neuraxial anesthesia, as Rezan showed already in the graph. Next slide, please. So we designed a study, a prospective study in von Willebrand disease, and prior it was the case that if your levels rose during pregnancy over 50, that you did not need the clotting factor or other treatment to prevent postpartum hemorrhage. But we saw a lot of postpartum hemorrhage by that time. And because of the normal population, there's a much higher rise in factor levels. We thought maybe we're giving them too late their factor. So we started this study, and now we treat our pregnant women with von Willebrand disease with clotting factor if they stay below 80 with their factor levels in the 3rd trimester of their pregnancy. And then we give them factor 8 and von Willebrand factor concentrate. And if they have levels over 80, we only give them tranexamic acid. That's mandatory for all women with von Willebrand disease in our protocol. And only factor concentrate or DDAVP if they have excessive bleeding. And we use definitions now for PPH, postpartum hemorrhage, that is more than 1 liter of blood loss within the first 24 hours, and also late blood loss needing medical intervention within 6 weeks after delivery. And these definitions have also been adopted by the 2021 guidelines for Willebrand disease that were made by multiple scientific organizations, including also the World Fed. We will present the first results of this study during ASH within 2 weeks, so I can't say much about it now, but if you're interested, you can maybe look it up later. So the multidisciplinary delivery plan is, I'm 100% on the same agenda as Rezan, that this is the most important thing to have for safe delivery, because the things go wrong when there's no plan, the plan is made too late, or it's not communicated. Then we get the problems. But if we have a multidisciplinary plan and we all agree it's ready on time, so from week 24 if possible, because when a preterm delivery occurs there should be a plan in place. The hemophilia treater is involved, the gynecologist, anesthesist, obstetrician, pediatrician, and clinical geneticist may all be involved in this plan, and it contains at least a diagnosis with the current results of the coagulation tests, so the 3rd trimester levels, also how the coagulation should be corrected depending on whether it's a vaginal or a cesarean delivery, and also dependent on the levels and maybe the bleeding tendency of the woman. Also advice on neuraxis anesthesia, and we always allow for anesthesia, neuraxial anesthesia, when the factor levels are corrected, not only spontaneously but also with factor concentrate. So then it's allowed to have an epidural, and that's very important for women. Also, we should state the policy regarding the child. When the child is affected with moderate to severe von Willebrand disease, we should be careful with the delivery not to cause bleeds, and also what to do if a postpartum hemorrhage occurs and who to call. That's also very important. Here in this slide, you can see it's quite old paper, but it's very neat that they check the levels some days after delivery. And what you see is that there's a significant decrease in von Willebrand and factor 8, especially on day 3. There we have the risk of the late postpartum hemorrhage, and we should educate women who have delivered on the fact that they might get late postpartum hemorrhage, because the levels will return completely to the pre-pregnancy levels within 3 weeks, and be prepared with what they have to do and when they have to call us.
So yes, as Karin mentioned, these factor levels really drop after delivery, and then that puts the women at risk of postpartum hemorrhage. And this is easy to understand why, because the uterus is after delivery is really still large. There's a large placental bed, and this takes about 6 to 8 weeks to be back to normal. And when you have the factor levels that already dropped with this large placental raw area, placental bed, there is the risk of hemorrhage. And these are all studies show higher rate of secondary postpartum hemorrhage in women with Willebrand disease compared to the 2% in the general population. So it is important that we educate our patients and healthcare professionals, especially those who look after the mother in the community after she's discharged home, about the high rate of secondary postpartum hemorrhage. And ask our patients to be alert. What is the normal blood loss after pregnancy? How long for? When and how should they ask for help? There should be really a good, clear pathway of management for clinician to follow if the bleeding happen. And in majority of cases, this is easy to control, and that's what we do in our clinic by giving tranexamic acid throughout the perperium until the bleeding completely stops. In majority of cases, they need up to 2 weeks, but they can extend further if the bleeding happy. It's also very important that we reassure the mother as well as the general practitioner and the community midwife that this is safe for breastfeeding and also does not increase risk of venous thromboembolism, because women often given very conflicting advice about these two issues that leads to discontinuation of the tranexamic acid during this critical time of after delivery and recurrence of bleeding. So now back to Karin to tell us why these varying international practices and which leads to increased risk of postpartum hemorrhage.
Yes, so this is also for this survey that has been done among healthcare providers, and there's varying practice with whether tranexamic acid is used to prevent postpartum hemorrhage, and it's not used or only in bleeding. Or only if there's a history of postpartum hemorrhage in over half of the cases. And it's important that the tranexamic acid should be given prophylactically, at least at the delivery, to prevent more bleeding. It has been proved to be safe and also prevents maternal death if you look worldwide, in women without a bleeding disorder. So it's important to use it. And here you can see the clotting factor concentrate. That was also very, but the most respondents did give factor concentrate in the more severe von Willebrand types. However, yes, please click on the slide. Yeah, so if you look at the map where these respondents were from, and then to the right to the map of the World Fed, with how many von Willebrand disease patients are reported in the world, then you can see that there's very, very wide disparity in quality of care. So even the gray countries did not even report any patients with von Willebrand disease. And there are many countries with very few von Willebrand cases per 100,000. And it's not likely that that's because of a lower prevalence, but because of lack of diagnostics and access to good care.
Okay, so one of the important aspects after delivery as well is beside preventing secondary postpartum hemorrhage through the prophylaxis with tranexamic acid or factor concentrate in severe cases, as just been mentioned, is providing the mother with a good contraceptive advice. So this chart represents the options that are available for a woman after delivery of what kind of contraception you can use. You can see plenty of them, and we don't have to discuss each one of them, but I'm happy to say that none of these options are contraindicated or could not be used in von Willebrand disease. The only caution I give is the copper-containing IUCD, because that will lead to increased bleeding and increased recurrence of heavy menstrual bleeding, so it should be avoided in women with von Willebrand disease. We know that women with Willebrand disease have heavy periods, and when they resume period after delivery, often, even in the normal woman, the periods start heavier. So that we have to keep this in mind when we're giving contraceptive advice, and choose an option that will be also helpful to reduce their menstrual loss. So levonorgestrone containing intrauterine device, which we refer to as Mirena intrauterine system, is really one of the most effective contraceptive advices options we have, with a failure rate less than 1/300 women, and it is one of the most effective treatment for having menstrual bleeding. It's also long-term contraceptive option that lasts up to 5 years. So I think this is a very good option for women after delivery, and the good thing that we can put it straight after delivery for the women, if we have discussed it in advance. Even after cesarean section, we can put it after delivery of the placenta. If we miss that opportunity, then we can bring them back 4 to 6 weeks after delivery to have insertion of Mirena IUS. The other very effective contraceptive and also very effective treatment for having menstrual bleeding is hormonal contraceptive, which can be come in a shape of pill or a patch or a ring, and these are also very good option for these women because they can control heavy periods and good contraceptive, and we can start the contraceptive pill 3 weeks after delivery if the mother is not breastfeeding, but those who are breastfeeding, to avoid interference with the production of breast milk, we can start at 6 weeks of gestation. Back to Karin to discuss the various challenges that they face.
Yes, I wasn't going into this on too much detail because it's also in the same publication as the Principles of Care for Women and Bleeding Disorders. It's just a reminder for healthcare professionals which issues they should take into account at the different life stages of a woman. And I think it's a really a good overview, so it can be used to make protocols or make sure that there's taking good comprehensive care of women with von Willebrand disease and other bleeding disorders.
Okay, so I hope we can conclude that women with Willebrand disease, they do have bleeding risk, and they face different challenges through different stages of their reproductive life, and this is especially true when they're planning pregnancy and throughout pregnancy and post-delivery. But should any woman with Willebrand disease be advised against pregnancy to avoid these complications? My answer is no, because it is possible to allow and help every woman with Willebrand disease, no matter what type of severity, is to have a safe pregnancy and delivery. And this is what we discussed earlier: advanced planning, early diagnosis of the condition, advanced planning, multidisciplinary planning, and support throughout pregnancy and post-delivery. And I think I'm going to refer back to these principles of care. Debra mentioned it, Karin mentioned it. I think it's very important that we are all aware of these principles of care, and maybe we can all, healthcare professionals, use it as a benchmark to set up and build our services for women with von Willebrand disease.
Yes, and just to add a few essentials, because I totally agree with the conclusions. There's limited published evidence regarding the optimal management of pregnant women with von Willebrand disease, unfortunately, but we're making progress. There are significant variations in clinical practice, especially regarding the Norexis anesthesia, and we should encourage that it can be done and is allowed after the factor deficiency has been resolved with factor concentrate, for example. And well, we remain to elucidate the optimal plasma levels to prevent postpartum hemorrhage. It's mandatory to give iron supplementation and do postpartum surveillance on late postpartum hemorrhage, and the use of tranexamic acid, because it's safe, it's cheap and easy, and it will help in reducing the amount of blood loss postpartum. And more effort is of course needed to reduce the global inequity in care for pregnant women with von Willebrand disease. I'll hand over back to Mariangela for any questions. We're happy to answer them.
Thank you. Thank you to all of you. It has been really clear, comprehensive with all the aspects. And also, I really want to really congratulate all of you because sometimes it's really complicated to keep the speech as, I mean, with all the context an expert can provide, but at the same time to keep it clear and delivered to everyone. So really thank you. I always say that because it looks like spontaneous and normal to do that, but I know it's really an exercise for disseminate the knowledge. So thank you very much. And indeed, we have several questions in the chat. So I will start in order from the first one. What are the indications for termination of pregnancy among women with von Willebrand disease?
So can I take that question?
Sure.
None because of von Willebrand disease, but of course any woman can choose to have termination of pregnancy for any other reason, like any other woman in the general population.
Thank you. Okay, so I can move to the next one, to hematologies. Do we need to give mandatory prophylaxis with type 3 von Willebrand disease during pregnancy? If yes, at what trimester?
No, it's not mandatory, and actually it's not common to give prophylaxis in von Willebrand disease. However, in type 3, it does prevent bleeding. So there are more and more patients with type 3 von Willebrand disease on prophylaxis, especially if they, for example, experience joint bleedings. And of course, there would not be a reason to stop this during pregnancy. If it's periodic prophylaxis just used for heavy menstrual bleeding, then it can be stopped during pregnancy because fortunately we don't have menstruations during pregnancy. But then we should restart it after delivery.
Thank you so much. There are some questions from Joe. Joe, would you like to actually ask them yourself?
Right, I'm going to have to scroll back and find them actually. So, sorry, I'm just trying to find the first one. So, can you tell us something about implantation bleeding? Is this more common in women with VWD?
Well, Joe, to be honest, we don't have data. We don't have data. We know implantation bleeding happens early in pregnancy around time of implantation, which could be just after the mother missed her period, up to 6 to 7 weeks of gestation. But we don't have data. We don't know. Even in general population, we don't know how many, because not every woman knows she's pregnant. Not every woman goes and reports the bleeding. So the answer, I don't know, and nobody knows.
I think that the next question, oh yes, also I had a question about access to spinal anesthesia. Do you consider this safe? I know with all 3 of my pregnancies, it handled very differently with all 3.
Karin, do you want to answer, or do you?
Yeah, I think that just illustrates the disparity in how physicians work with this, and that should be it should get better if guidelines say that we can use the anesthesia after supplementation of factor.
Yeah, so in my first one, it was an absolute no, you can't. In my second one, it was an absolute no, you can't. We'll have to give you a full anesthetic. And in number 3, it was, we won't use an epidural, but we'll use the spinal block as long as we've given you the factor replacement beforehand. They're quite different experiences.
Yeah, so there are the key to a safe epidural is the assessment beforehand and the plan. So if we see the mother before she's due to deliver, and then assess what is her factor level, what are her bleeding risk, and decide what level of prophylaxis she needs to make it safe, and also to educate and involve the anesthetists, because often mothers comes middle of the night, neither hematologist or the gynecologist involve the care there, then they just are scared of von Willebrand disease and they will deny the mother this option. But if we involve them in decision and we have a clear plan, then it is possible for majority of women to have a safe epidural, or and spinal is safer because it's a thinner needle and it's in and out, rather than the epidural, which is a thicker catheter, and it's a catheter that stays there for hours during labor and delivery.
Yeah. My next question, sorry, I feel like I've asked loads of questions. My daughter's consultant told her that tranexamic acid had not been tested on humans for safety in pregnant women, only on mice. And that unnerved her. Has things moved on since this advice? So that was 2 years ago.
Yeah, that's true. We don't know if it's safe during the pregnancy, so we don't prescribe it during pregnancy. Just only a little bit of the tranexamic acid. It also works locally. So if you have a gum bleed, you can put a little bit of the powder on it with tranexamic acid, or make a bit of a tranexamic acid fluid with a bit of water. So a little bit locally is, I do say that women can use it, but it's not been tested. So we're not sure.
Well, for us, we use it very liberally. I use it even in women without von Willebrand disease or bleeding disorder, if they have early pregnancy bleeding or even hematoma. And there are some animal studies that show no effect, and we are like very liberal with it. Debra knows that. But yeah, if we need evidence for everything, then like Professor Teddenham used to say, then should we not use the parachute when the plane is, crashing? So, yeah, but I think it's quite safe.
I think
that comes up to counseling then.
Yeah.
I think it's also worth adding that tranexamic acid was licensed a very long time ago, if we look at all the things that we use. And so how things were licensed and examined then are very different to how we would do it today. I take your point that there haven't been the studies, but I think there are a number of clinicians who do use it widely within pregnancy.
I mean, my daughter was prescribed it, but then also told, oh, we don't know if it's safe, which is unnerving if you're, you're a newly pregnant woman and you're thinking, oh. My last question was, given the risk of higher rate of secondary postpartum hemorrhage and the risk during delivery when you're not actually sure if baby also has VWD, is it objectively safer to have a vaginal birth or a C-section in women with VWD?
We always advise for normal vaginal delivery if possible, but when the child has von Willebrand disease, we can test it with prenatal diagnostics if we want to know, for the sake of the delivery, or if we don't know and it could be quite severe von Willebrand disease, then we say be careful with the delivery, and we say to the gynecologist, do it without trauma, so no vacuum, no blood testing on the head. I think Rezan can tell more about that.
Yeah, I agree. I mean, von Willebrand itself should not, for the mother, should not affect, but obviously if the baby is expected to have type 3, then it is, we have to treat as if the baby has a severe bleeding disorder, and then maybe we can discuss with the mother. And it also depends very much on the mother's obstetric history. If a mother who has given 3 previous normal deliveries within like 3-4 hours without any difficulties, then it's obvious that she's going to have normal delivery, but with the cautions that we should not let her to go on if it's not progressing and do a traumatic delivery. But if the mother who is a primary gravida and she's already overdue and we think the baby is going to be affected some way or another, we don't need to really be very keen on the vaginal delivery, because sometimes vaginal delivery can start, but then we know there are high risk of ending up with an emergency cesarean section if it is induction of labor and prolonged labor, which is more risky from bleeding point of view than a planned cesarean section. So it's a balance and really individualizing care for each woman separately, taking everything in consideration.
And is there a way to test the baby for VWD before the baby's actually born, so in uterus?
Yeah, we do this with a punction of the fluid late in pregnancy. So in 32 to 34 weeks, if there's a known mutation, we can test whether the baby is affected or not. And that has some influence on what to do with the delivery, because if the baby is not affected, there are no restrictions for the gynecologist, and there's a bit bigger chance that it will end up with a vaginal delivery.
So Joe, with von Willebrand disease, it's only if you know the genetic, and then in type 1, obviously, genetic is not done. But if the genetic is known in type 2 and also type 3, then as Karin said, we can even test in early pregnancy with CBS and know it. And for those who don't want to do that, we can do it in 3rd trimester and check whether we can confirm the mutation is carried by the baby.
But that's not needed when it's a mild type of Willebrand disease, because then during birth there's a lot of stress in the baby too, and that will rise the levels. So that's not a danger for bleeding. That's safe.
Thank you for answering my questions. Sorry for hogging the floor.
Thank you. Yes, Dara, do you want to go? Sorry, we overlapped.
I just wanted to ask if you wanted to read, or I can jump in. So, question from another co-chair of the EHC von Willebrand Disease Committee. Should a pregnant VWD patient plan to deliver the baby in a hospital which also has a hemophilia treatment center, or it is also safe enough to deliver a baby just in a normal hospital if treatment is planned and discussed in advance between hematologist and the normal hospital?
I think that may be a little bit different in different countries, but and depends on the availability of hemophilia treatment centers and birth care. But in our country, it's mandatory to deliver in a hemophilia treatment center if you need clotting factor concentrate. If not, you can also deliver in another hospital under our with our birth plan, of course.
Thank you.
Okay, so I will note that has been taken. Sorry, I was reading through.
From what I see, we don't have any questions really.
Yeah.
Because there are quite some messages just thanking the speakers. Although there are 2 people from Somalia attending our webinar. I know very well online Mr. Ahmed, because he's very active, although of course at the EHC we deal with the European countries, but so he's a patient and clinician himself, healthcare professional, and he always tries to help patients in the country. And we actually have a clinician also, Mahmoud Akli, attending this webinar. So the question was, since they don't have access to factor in Somalia, what actually they can do if the treatment is not available, some tips probably that you could share, what can improve life of, in this case, I guess we focus on women with von Willebrand disease.
So that
If any, of course.
Of course, there are obstetric measures that can be made to make sure the blood loss is as less as possible, as few as possible. How did I say that? Yeah. Tranexamic acid can be used. That's safe and available and cheap. I think it's also possible to contact the World Federation of Haemophilia in these cases for individual problems, and then they might help with getting the factor for individual cases, but I'm not sure about that. Maybe you know that better.
Yeah, they have the issue. That's what Mahmoud Akli mentioned in his comment, that he has, as a clinician, number of cases suspected undiagnosed bleeding disorder. since the factor assay measure is not available in the country. And that's actually also an issue that many patients are just even undiagnosed. So we don't know if they are actually von Willebrand patients or hemophilia or extremely rare bleeding disorder.
So luckily, women don't bleed that much during pregnancy, so that's good. But we have tranexamic acid, and for delivery, I think again advanced planning. If the woman is really at high risk, then maybe referring to another place that they can have the hemophilia treatment center in advance. Otherwise, like Karin mentioned, prophylactic tranexamic acid, making sure delivery is atraumatic, using extra-uterotonic, the medication that is available, such as misoprostol, which is commonly used in all the African countries to contract the uterus. Even in our center, we give 2 uterotonics for these women so that we don't allow, because uterine atony is the very common cause of postpartum hemorrhage, about 70% of women. If we use appropriate and effective uterotonics, then we minimize risk of postpartum hemorrhage. The other thing Karin mentioned earlier, make sure that the patient is not anemic. Actually, make sure that she's really have very good hemoglobin before approaching delivery time, so that if she has a bit of bleeding, she can tolerate it better.
Thank you very much. Considering that also we have run out of time because we start a little bit later, I don't know if there is a very last quick question or if we to close the session, thanking again the expert and the audience for being with us. Okay, so I think we can enjoy our evening after this incredible session on this very important topic on maternity. And I really want to thank again all the speakers for being with us, the audience, and of course, the incredible support and co-coordination of the EHC. So thanks, Daria, a lot, and all the from Willebrand Disease Committee, of course, for this great collaboration. Thank you so much.
Thank you, everyone. Thank you, Mariangela. And
Thank you.
see you very soon, because our next webinar is on aging with von Willebrand disease, and it will take place in a week.
Yes.
So we see you. Please join us.
Yes. See you very soon. Bye-bye.
Thank you. Bye.
Bye-bye. Thank you.